Welcome to our comprehensive overview of chemical plaque control. In this video, we'll explore how chemical agents, especially mouthwashes and antimicrobials, play a crucial role in maintaining oral health. Chemical plaque control is not just about fresh breath, it's a scientifically proven adjunct to mechanical cleaning, helping to reduce gingival inflammation and prevent the recurrence or progression of periodontal disease. Whether you're recovering from oral surgery, struggling with recurrent gum problems, or simply seeking more effective plaque management, understanding these chemical strategies is essential. Let's begin by examining when and why chemical plaque control is clinically indicated. Chemical plaque control is particularly valuable during Phase 1 periodontal therapy for patients with recurrent oral health issues or when mechanical plaque control is ineffective. It's also recommended after periodontal or oral surgery, providing an extra layer of protection during healing. For individuals with limited dexterity or those wearing orthodontic appliances, chemical agents can make a significant difference. By targeting bacteria and reducing inflammation, these agents help maintain oral health when brushing and flossing alone may not suffice. An ideal mouthwash should do more than just freshen breath. It must selectively eliminate pathogenic microorganisms, prevent the development of resistant bacteria, and exhibit substantivity, meaning it remains effective in the mouth for an extended period. Safety is paramount. The solution should not harm oral tissues at recommended concentrations. Additionally, it should significantly reduce plaque and gingivitis, inhibit calculus formation, avoid staining or taste alteration, and be user-friendly and cost-effective. These properties ensure both efficacy and patient compliance. Chemical plaque control can be approached in two main ways: prevention and treatment. Preventive agents focus on stopping supragingival plaque from developing, while therapeutic agents target subgingival plaque, which is often more challenging to control. This distinction is important because different agents are designed for specific roles in oral care. Understanding which approach is needed helps dental professionals tailor recommendations for each patient's unique needs. Chemotherapeutic agents are further classified as nonspecific or specific. Nonspecific agents reduce all plaque bacteria uniformly, leading to an overall decrease in plaque. Specific agents, on the other hand, act like a silver bullet, targeting only the bacteria responsible for periodontal disease. This targeted approach can be especially beneficial for patients with persistent or severe gum issues, as it minimizes disruption to the beneficial oral microbiome. Antimicrobial agents are grouped based on their efficacy and substantivity. First-generation agents reduce plaque by 20–50% but require frequent use due to poor retention. Second-generation agents, with better retention, reduce plaque by 70–90% and are used less often. Third-generation agents are highly specific, targeting particular periodontopathic organisms. This classification helps clinicians choose the right agent for each clinical scenario, balancing effectiveness with convenience. First-generation antimicrobial agents include antibiotics, quaternary ammonium compounds, phenols, and sanguinarine. These agents reduce plaque scores by 20–50%, but must be used 4 to 6 times daily due to their limited retention in the oral cavity. While effective, their frequent application can be inconvenient for patients, which is why newer generations are often preferred in clinical practice. Second-generation agents, such as bisbiguanides, are retained longer in the oral cavity, allowing for sustained antimicrobial action. These agents reduce plaque by 70–90% and require only 1–2 uses per day. Their improved substantivity makes them more convenient and effective for long-term plaque control, which is why they are often considered the gold standard in chemical plaque management. Third-generation antimicrobial agents are designed to target specific periodontopathic organisms. By focusing their action on the bacteria most responsible for periodontal disease, These agents offer a highly tailored approach to oral care. This specificity helps preserve the balance of the oral microbiome while effectively managing disease-causing bacteria. Addy's classification organizes chemical agents for supragingival plaque control into several categories: antibiotics, enzymes, quaternary ammonium compounds, bisbiguanides, metallic salts, herbal extracts, fluorides, oxygenating agents, phenolic compounds, and other antiseptics. Each category includes agents with unique mechanisms and clinical applications, providing a wide range of options for individualized patient care. Antibiotics such as penicillin, vancomycin, kanamycin, erythromycin, spiromycin, and metronidazole are sometimes used for supragingival plaque control. These agents work by inhibiting bacterial growth or killing bacteria outright. However, due to concerns about resistance and side effects, their use is generally reserved for specific clinical situations rather than routine plaque management. Enzymes like mucinase, protease, lipase, amylase, elastase, lactoperoxidase, hypothiocyanate, and mutinase help break down plaque matrix components, making it easier to remove. By targeting the structural integrity of plaque, these enzymes support mechanical cleaning and enhance overall oral hygiene. Quaternary ammonium compounds, including cetylpyridinium chloride, benzethonium chloride, benzalkonium chloride, and dimethyl bromide, are cationic antiseptics. They are especially effective against gram-positive bacteria and early plaque formation. Their surface-active properties help disrupt bacterial membranes, making them valuable in mouthwash formulations. Chlorhexidine is the gold standard among bisbiguanides, widely used in periodontal therapy. It is highly effective as an adjunct to mechanical oral hygiene, especially during initial therapy, after surgery, and for patients with limited plaque control abilities. Chlorhexidine is also beneficial for those with orthodontic appliances, drug-induced gingival overgrowth, or recurrent oral infections. Chlorhexidine is indicated for use after oral surgery in patients with fixed orthodontic appliances and for those who have difficulty maintaining oral hygiene. It helps control plaque in cases of drug-induced gingival overgrowth, recurrent oral infections, and local oral conditions like denture-induced stomatitis or aphthous ulcers. It is also used prophylactically to reduce bacteremia risk after dental extractions. Chlorhexidine exhibits a broad spectrum of antimicrobial activity, being more effective against gram-positive bacteria. At high concentrations, it is bactericidal, while at lower concentrations, it is bacteriostatic. The cationic molecules bind to bacterial cell walls, disrupting membrane transport and causing leakage of cellular contents. At higher concentrations, it penetrates cells and precipitates the cytoplasm. The pincushion effect describes how one end of the chlorhexidine molecule binds to the tooth surface, while the other end remains available to interact with approaching bacteria. This unique property enhances its substantivity, allowing chlorhexidine to provide ongoing antimicrobial action as bacteria come into contact with treated surfaces. When 10 milliliters of 0.2% chlorhexidine is used as a mouthwash for 1 minute, about 30% of the drug is retained in the mouth due to its substantivity. Small amounts that are swallowed are not harmful, as chlorhexidine is poorly absorbed from the gastrointestinal tract and is excreted in feces. Studies show that 0.12% solutions are equally effective for long-term use. Chlorhexidine is available in different concentrations and brands. Commonly used concentrations include 0.2%, brands like Rexidine, Hexidine, Clohex, and 0.12%, Periogard. These products are widely used in dental practices and are often recommended for home use in specific clinical situations. While chlorhexidine is highly effective, it cannot completely replace mechanical plaque removal methods like scaling and root planing. It is best used as an adjunct to these procedures, providing additional antimicrobial action but not serving as a standalone solution for total plaque control. Despite its benefits, chlorhexidine has some unwanted effects. These include extrinsic brown staining of teeth, painful or desquamative oral lesions, impaired taste sensation, rare parotid swelling, dryness and soreness of the mucosa, and increased calculus formation with prolonged use. Patients should be informed about these potential side effects before starting therapy. Phenolic compounds and essential oil rinses are proven to reduce plaque and gingival scores. They work by penetrating the lipid components of bacterial cell walls, especially in gram-negative organisms, causing structural damage and disrupting metabolic processes. Additionally, phenols have anti-inflammatory properties, inhibiting neutrophil activity and prostaglandin synthesis. Quaternary ammonium compounds act as cationic antiseptics and surface active agents. They bind to phosphate groups in bacterial cell walls, teichoic acid in gram-positive bacteria, and membrane lipopolysaccharides in gram-negative bacteria. The lipophilic portion disrupts membrane integrity, leading to leakage of cytoplasmic material and bacterial death. Disclosing agents are valuable tools for highlighting dental plaque, allowing patients to visually assess their oral hygiene. Common agents include erythrocine dye, FDC-No, 3, two-tone dyes that differentiate new and old plaque, and the plaque light system, which comes as wafers, tablets, or solutions. These agents make it easier for patients to identify areas needing better cleaning. Erythrocine dye, FDC. Number 3 is commonly used to highlight plaque. Two-tone dyes go a step further by coloring new plaque red and older plaque green or deep violet. This differentiation helps patients and clinicians identify areas where plaque has been accumulating for longer periods, guiding more effective cleaning strategies. The plaque light system offers wafers, tablets, or solutions that are swished around the mouth. Excess dye is then rinsed away, leaving only the areas with plaque stained. This simple and effective method empowers patients to monitor and improve their oral hygiene at home. Anti-calculus agents, also known as crystal growth inhibitors, are designed to prevent the mineralization of plaque into calculus tartar. These agents work by reducing the amount of plaque available for mineralization, modifying plaque attachment, or directly inhibiting the mineralization process. Their use helps maintain smoother tooth surfaces and reduces the risk of gum disease. One strategy for preventing calculus is to reduce the amount of plaque available for mineralization. This can be achieved through the use of antibiotics and antiseptics, which lower the bacterial load and disrupt the plaque matrix, making it less likely to harden into calculus. Anti-adhesive agents, such as silicone and ion exchange resins, modify the attachment of plaque to tooth surfaces. By interfering with the ability of bacteria to adhere, these agents make it easier to remove plaque during routine oral hygiene practices, further reducing the risk of calculus formation. Enzymes like mucinase or high concentrations of urea, 30%, can inhibit the mineralization of plaque. By breaking down the organic matrix or altering the chemical environment, these agents slow or prevent the transformation of soft plaque into hard calculus. Mineralization inhibitors such as pyrophosphates, diphosphonates, and zinc salts are effective in preventing the crystallization of minerals within plaque. These agents are commonly found in anti-tartar toothpastes and mouthwashes, helping to keep teeth free from hard deposits. A variety of anti-calculus agents are available commercially, including vitamin C, pyrophosphates, diphosphates, metal salts, sodium fluoride, and gantrez copolymer. Popular anti-tartar brands like Crest and Prevent incorporate these ingredients to help consumers maintain calculus-free teeth. Phenolic compounds, such as thymol, menthol, and eucalyptol, exert their antibacterial action by penetrating the lipid-rich cell walls of bacteria. This disrupts membrane permeability, interferes with substance exchange, and impairs enzyme-dependent metabolic processes, ultimately reducing bacterial viability. Beyond their antibacterial effects, phenolic compounds also reduce inflammation. They inhibit neutrophil chemotaxis, decrease the generation of superoxide ions, and block prostaglandin synthase production. These actions help control gingival inflammation and support overall gum health. Oxygenating agents like hydrogen peroxide are used to control supragingival plaque. They work by releasing oxygen, which disrupts anaerobic bacterial colonies and helps break down the plaque matrix. These agents are particularly useful in managing acute oral infections and promoting wound healing. Metallic salts, such as copper, tin, and zinc, are included in some oral care products for their antimicrobial properties. These metals interfere with bacterial metabolism and inhibit plaque formation, contributing to overall oral cleanliness. Herbal extracts like sanguinarin are used in some mouthwashes for their natural antibacterial properties. While not as potent as synthetic agents, they offer an alternative for patients seeking more natural oral care options. Fluorides, such as strontium fluoride, are well known for their role in preventing tooth decay. They also contribute to plaque control by inhibiting bacterial metabolism and enhancing enamel resistance to acid attacks. Other antiseptics used in chemical plaque control include iodine, povidone iodine, sodium hypochlorite, hexetidine, and triclosan. Each of these agents has unique properties and applications, providing additional options for managing oral bacteria and maintaining oral hygiene. Chemical plaque control is a multifaceted approach that complements mechanical cleaning. By using a variety of antimicrobial agents, mouthwashes, and anti-calculus strategies, dental professionals can help patients achieve better oral health outcomes. Understanding the mechanisms, indications, and limitations of each agent is key to effective and personalized oral care. Educating patients about the benefits and limitations of chemical plaque control is essential. Clear communication helps set realistic expectations and encourages adherence to recommended oral hygiene routines. Patients should understand that chemical agents are most effective when used alongside regular brushing and flossing. Selecting the appropriate chemical agent depends on individual patient needs, oral health status, and risk factors. Dental professionals consider factors such as efficacy, side effects, patient preferences, and cost when making recommendations. Personalized care ensures the best possible outcomes for each patient. Research into new antimicrobial agents and delivery systems continues to advance the field of chemical plaque control. Innovations such as targeted therapies, sustained-release formulations, and natural alternatives hold promise for even more effective and patient-friendly oral care solutions in the future. To sum up, chemical plaque control is an essential adjunct to mechanical cleaning, offering a range of agents and strategies to combat plaque and prevent oral disease. By understanding the properties, mechanisms, and clinical uses of these agents, both patients and professionals can work together to achieve optimal oral health. Thank you for joining us in this comprehensive look at chemical plaque control. By integrating antimicrobial agents, mouthwashes, and anti-calculus strategies into daily routines, we can significantly improve oral health outcomes. Stay informed, consult your dental professional, and remember that a healthy smile starts with effective plaque control.